Hello. My presentation that I'll be discussing today is regarding bladder injury during scheduled versus emergent cesarean sections. According to the Center of Disease Control and Prevention, the cesarean section rate in the United States was 31.9% in 2020. This is one of the most common surgical procedures done in the United States yearly. 86.2% of women who have a history of a primary section will have a repeat C-section for their future pregnancies. A study by Hagar et al. In 2004 reported an overall complication rate of 21.4% during a C-section in their prospective study. Bagolti in 2003 found that the rate of complications in an emergency C-section was 14.5% compared to elective C-sections with a rate of 6.8%. Phipps et al. In 2005 found an incidence of 0.28% for bladder injury with an incidence of 0.56% during a repeat C-section and 0.14% during a primary C-section. Rahman in 2009 found that repeat C-sections in the presence of adhesions were considered to be a risk factor for bladder injury. The questions I looked at were, is there a difference in the incidence of bladder injury during emergent cesarean sections as compared to scheduled cesarean sections? And was there a difference in the incidence of bladder injuries during the repeat cesarean section compared to a primary cesarean section? As far as the hypothesis goes, our null was that there was no association between the incidence of bladder injury and the timing, emergent versus scheduled, of the C-section, as well as there being no association between the incidence of bladder injury and the occurrence of either repeat versus primary of the C-section. Whereas the alternative was that there were associations between the incidence of bladder injury and the timing, and bladder injury and the occurrence of the section. We conducted a retrospective chart review of adult women who underwent either a scheduled or emergency C-section delivery from January 1, 2013 to December 31, 2020 at Ascension St. John Hospital. Patients under the age of 18 years were excluded. Patients with failed induction, arrest of labor, arrest of descent, failed a trial of labor after cesarean section were considered emergent. We collected data on patient age, body mass index, gestational age at delivery, primary versus repeat cesarean section, reason for their cesarean section, surgery details, bladder injury noted at the time of surgery, if the patient had been laboring, anesthesia type, and if a urogynecology or urology consult was placed. The primary endpoint was the incidence of bladder injury. When a bladder injury was identified, the operative note was then reviewed to see if a bladder flap had been completed. Data was analyzed using a chi-score test and a student's t-test. Analysis were conducted with CPSS version 25.0 and a p-value less than 0.05 was considered to indicate statistical significance. A total of 8,488 cases were reviewed. A total of 28 or 0.3% of cases were noted to have a bladder injury, and 11 or 39% of these cases did have a bladder flap that was completed during the cesarean section. This table here breaks down the age, BMI, and gestational age of our two groups. Our two groups are our bladder injury group and our no bladder injury group. The age between the two have a difference of approximately 1 year. The BMI is pretty similar, however, off by about 2, and our gestational age is similar at about 37. This table discusses the labor of each patient. In each group, we look to see if the patients were in active labor. 32% of the no bladder injury group were laboring, whereas 57% of the bladder injury group were laboring, with a p-value of 0.004. The median cervical dilation for both groups were 0. If a patient did have a scheduled C-section and they had not been complaining of contractions, they were assumed to be 0 centimeters dilated. This has a p-value of less than 0.0001. And the majority of our patients receive regional anesthesia, with only a few in each group receiving general. This goes into further detail about the delivery and the post-delivery aspect of each patient. Of the bladder injury group, there was no failed operative deliveries, whereas in the no bladder injury group, there were 71. As far as the cesarean section and the timing, whether it be emergent versus scheduled, was also broken down. Of the 28 bladder injury groups, 18 of them were emergent and 10 were scheduled, whereas in the no bladder injury group, 3,820 were emergent, as well as 4,640 were scheduled, with a p-value of 0.04. As far as being primary or repeat, the majority of bladder injuries occurred in the repeat group, whereas it was about 50-50 for the no bladder injury group. The majority of our patients did have Foley catheters in place, and there was only one urogynecology consult that was placed in the no bladder injury group, whereas almost all but 4 of the bladder injury group had a urogynecology or a urology consult placed intraoperatively with a p-value of less than 0.0001. So for our discussion, we did find that there was an association between bladder injury and it being an emergent C-section with a p-value of 0.04, bladder injury and being a repeat C-section with a p-value of 0.01, and bladder injury and having a urogynecology or urology consult placed with a p-value of less than 0.0001. So although bladder injuries are still rare, we had about 0.3% in our study, physicians should be aware that there is an increased risk of these injuries in these situations and act accordingly. A trial of labor after a cesarean section should be considered, and a creation of a bladder flap should also be considered with emergent and repeat C-sections, as we know that there is an association with having a bladder injury in these cases. Our study limitations include the fact that here at St. John we do have many different surgeons, and each surgeon has their own surgical technique, so this could not be accounted for. This was a retrospective study. Prior surgical history was not taken into account, and it's well known that with surgeries there is adhesive disease that will form, and so the extent of this adhesive disease was not always noted in charts or taken into account during our data collection. And then creation of a bladder flap was only collected if a bladder injury was noted during that case. So in conclusion, bladder injury at the time of C-section is uncommon with only a 0.3% incidence. We found that there was an association between bladder injury and emergent C-sections as well as repeat C-sections. And if a bladder injury did occur, a urologist or a urogynecologist is likely to be called in for evaluation and repair. These are my references. Thank you.